Hello, good afternoon, everyone. On behalf of the Department of Rheumatology and Clinical Immunology, myself, Dr. Kavita Krishna, Dr. Varsha Bhatt, Dr. Sandeep Kansurkar, Dr. Jitendra Oswal, we invite all of you to the workshop on osteoporosis today. Conversations on osteoporosis, key lessons from the clinic. We have a very esteemed faculty who has come from UK to be with us today, Dr. Kaushik Chaudhury. He's a renowned rheumatologist at the University Hospitals of Coventry and Warwickshire. He's the former head of department and is osteoporosis lead over there. Dr. Chaudhury has had a long-term interest in undergraduate and postgraduate medical education and training. He co-founded the Indo-UK Rheumatology Forum in 2005. He's affiliated to the Warwick University Medical School and also with the Master of Medicine course at Edge University. He has been a regional chair member of Council Chair of Education and Training and the Secretary of British Society of Rheumatology. He has been an elected councillor at the Royal College of Physicians, London, and he's currently the president of the European Union of Medical Specialists, Rheumatology section, as well as on the Education Committee of ULAR and their council. He's part of the clinical reference group for rheumatology in NHS England and also a member of the revalidation and assessment panel of General Medical Council. He helped with the establishment of the osteoporosis special interest group at Hyderabad Aracon in November 2023. He's a keen advocate for rheumatologists to take a greater interest in matters related to bone health. Yes, bone health is very much neglected in females as well as in males. So let us learn more about the prevalence and the problem with osteoporosis in our country and how to deal with them. The key factor in holding this workshop today was another favorite and renowned rheumatologist of the city, our own Dr. Arvind Chopra, sir. So I welcome you today and request you to come and please take the chair. Please, sir, please come. I now request Dr. Kaushik Chaudhury to start the workshop. It's going to be interactive, so do silently, please put your questions in the chat box. They will be answered as the workshop goes on. Thank you. So.
Thank you very much, Professor Krishna, and a warm welcome to Dr. Arvind Chopra. He and I go back several decades. Thank you all for giving up your time to come to the this workshop, as we call it. Osteoporosis is something that I came into a bit late in my career, and it happened by chance. And about 10 years ago, I had to take up the osteoporosis clinic because of a retirement in our department. And from then on, it's evolved. And I realize every day when I see these patients that how complex it is, which I had not appreciated before. And also from a rheumatology perspective, there is a lot for us to do and to learn from each other. There was a great deal of interest in the special interest group and the workshop we did in the recently concluded annual conference of our society in Hyderabad. And this is part of that process of raising the profile of osteoporosis, not just within rheumatology, but within the wider medical community, because I think it needs to be done. And what I will do in the first half of this session is take you through the key elements. Some of you may be very familiar with them, others may not be so. And the other thing I need to emphasize is please use the chat box for those of you who are very tech savvy, and others who are not, like me. Just raise your hand, interrupt me, stop me. And the whole purpose is to have an interactive session. There is no question that isn't important, and feel free that you can interrupt me. If I can, I shall answer it. If not, we will make a note of it and I will get back to you. I'm not an expert in the true sense of the word. I'm just an educated amateur, if you like. You know, in golf, you have amateurs and professionals. I'm on the sort of slightly higher handicapped amateur in terms of osteoporosis. Yeah, right. Frozen. That's it. Okay, I'll press this. Oh, it's come back. So I start with my deep gratitude and thanks to Professor Krishna and her team, as well as to Dr. Chopra, and to colleagues who are the real experts, who teach us. I work and live in the UK, and I go to these sessions and I learn a lot. We also have a regional bone interest group there, and we bring our difficult cases there, and we again learn from each other. And what it has, to some extent, it's reassuring to know that osteoporosis is one of the last bastions of eminence-based medicine. There are so many situations where really there isn't much evidence, and that's where experience and good clinical acumen come into play. I'd like to acknowledge the help from Dr. Chamit Roda, who's my senior clinical fellow. He's from Sri Lanka, from Colombo. He does the osteoporosis clinics with me, and he has helped with some of the case vignettes. And to Mr. Kaushik Gupta from Brinton Pharma for their support and help with this event. So I live not far from Stratford-on-Avon, which is the birthplace of William Shakespeare. And what that quote, or you can see that is a statue there of Hamlet. And you will all know the quote from Hamlet, which is to be or not to be. And in some ways, when you're faced with some of these complex osteoporosis patients, this quotation comes to mind. The first point I'd like to address is, why should we be interested in osteoporosis at all? And why should we bother? Then, of course, it's about how we go about tackling osteoporosis. Whether, about DEXA scanning, the use of fracture prediction tools. We will then break for a short break, and then we'll present some cases, and then go on to a little bit about treatment. So what is osteoporosis and why is it important? As you can see from this photomicrograph, the difference between normal bone and osteoporotic bone is quite obvious. And it is not hard to imagine why, if there is a certain amount of force to the porotic bone on the right-hand panels, they will have a fracture. It is also important to remember that although osteoporosis awareness has improved over the last 2 decades, there is still a lot of ground to cover. One of the advantages of osteoporosis is that it is dealt with a large number of specialties, with orthopedics, rheumatology, endocrinology, but that is also its weakness because it is not clear who takes ownership of these patients, particularly in certain organizations like ours. It's kind of the lines are blurred. There are not that many treatment options. And therefore, it is important that we understand how to use them in a sensible way. So my key message today, if you forget everything else, is that you think of osteoporosis. If you are from a rheumatology background, it is an incredibly important comorbidity for our patient population, but also with an aging population in countries all over the world, but also in India, it is going to be an incredibly important public health problem in the decades to come. So once you have thought of osteoporosis as being part of the problem that the patients comes to you, they may come with other problems, then it is important to know how to assess and measure it sensibly and then treat it pragmatically. So why should you be interested in osteoporosis? By 2050, which is only 30 years away, there will be 21.3 million hip fractures a year globally. With India having 1.6 billion people by then, we will have our share of millions of people with avoidable low trauma fractures. 80 to 90% of osteoporotic fractures in the world go untreated. And I will show you some data which suggests that osteoporotic fractures come at great personal and societal costs. A fragility fracture is a warning sign that has to be taken seriously, and we have to put it in the right perspective. But you might say, well, it's a problem of the Western world. They have a different demographic population. It's not really a problem in India. Think again. It is an emerging problem. It's already an existing problem. And unless we take measures now, we will have even more problems. So as far as the Indian scenario is concerned, the prevalence of osteoporosis is 8 to 62% across the board. Work is in progress to look at the rheumatology population, and obviously, I'm sure the prevalence will be more. It is not just a problem with postmenopausal women, which is sometimes in the public consciousness. Males get osteoporosis too, and we will present some cases in the second session, which will highlight that. Obviously, the females predominant, postmenopausal women in particular, in a ratio of 3:1. Urbanization has led to changes in the way our lifestyle has evolved. We are more sedentary, our diets have changed, and as a result, there is more prevalence of osteoporosis in urban population. And overall, there is low awareness. This is a few facts from NOG, which is a National Osteoporosis Guidance Group, which is our guiding light in the United Kingdom. And I recommend you all to have a look at the latest NOGG guidance. If you just Google NOGG, there is 2021 guidance. And it makes sobering reading. 1 in 2 adult women and 1 in 5 men will sustain 1 or more fragility fractures in their lifetime. Just pause and think about it, ladies and gentlemen. Half the women of a certain age will have some form of fragility fracture. They will not all have hip fractures, but they may well have a wrist fracture or vertebral fracture. Currently in the UK, there are about 500,000 new fragility fractures occurring every year. And the cost of a fragility fracture, particularly a hip fracture, is around 15 to 20,000 pounds a year. A large number of these hip fractures could be avoided if we had the proper measures in place. It costs nearly 5 billion pounds. And if you extrapolate these figures to a country as big as India, and yes, the unit cost may be different, but it's still a huge cost. This isn't just the UK. The IOF, International Osteoporosis Federation, came out with a very sobering and very worrying report a few years ago about the situation in Europe. And they headlined it with the title, Broken Bones, Broken Lives. And that is what I'd like to impress upon you. Fragility fractures impact on the lives of these patients, and I'll show you how. Let us take, for instance, a hip fracture. If you have a hip fragility fracture, the neck of femur osteoporotic fracture, the mortality after a year is 20%. So 1 in 5 elderly women will die within 12 months of that hip fracture for a whole variety of reasons. Permanent disability for 30%. In the Western societies where they are self-caring and independent, they are robbed of that independence. They rely on other people. They often have to be institutionalized because of these fractures. So it is in our interest, and it's not just in the West. In the urban cities of India now, a lot of people are in institutions. And therefore, the yellow arrow, it sounds like a headline in the tabloid press, but it is a fact. You're not looking at a hip fracture, but you're looking at a death sentence. It may seem sensational, but the facts bear it out. And then there is the personal cost. This was a survey conducted by what was then the National Osteoporosis Society. It's now called the Royal Osteoporosis Society. And look at what they're saying. Frustrated, upset, self-conscious. None of these are positive reactions to an osteoporotic fracture. This is what the person who has had this osteoporotic fracture is experiencing. And it is a severe enough problem that we have had an all-party parliamentary group in the United Kingdom across the board in the House of Commons who've come out with not one, but two reports about the poor state of services in the UK when it comes to osteoporotic fractures. And we'd like to think we're among the better organized countries in terms of relation to osteoporosis. And that is clearly not enough. So other countries where none of these exist, you can imagine what the situation is. And I don't want to be alarmist, but it's better to take note of these now. So we put in initiatives that will hopefully avoid us going over the precipice in the next 20 to 30 years. And it's a question of whose baby is it? And those of you of a certain age will have read stories about, disappearance of planes and ships in this area in central and in Atlantic for the Bermuda Triangle. And osteoporosis care is something that gets lost in the Bermuda Triangle between orthopedics, primary care, and the osteoporosis specialists who could be endocrinologists or a rheumatologist or some other specialty, gerontologist, for example. And because of the morbid consequences of osteoporosis, the prevention of this condition and its associated fractures is considered essential to the maintenance of health, quality of life, and independence, particularly in the elderly population. And this is something that we should at least strive for. And I'll read it out for you because every word is important. Fragility fractures are a global healthcare emergency. We know that we need about 4 out of 5 coverage or 80% coverage of fractures to be identified. And then even if we manage to treat half of those fractures, that's good enough. 80% of these start and stay on treatment. Stay is important. A lot of these patients do not stay on treatment. We can achieve an optimal number of fractures avoided. Currently, we are far below that standard. And it makes economic sense. If you compare whether there is benefit in investing resources into the care of osteoporotic fractures, it actually comes just below stroke and blood pressure and is better than heart disease, hyperlipidemias, and all the rest of the other long-term conditions. This is a study from Japan, but I think it's generalizable to the rest of us. So now that I have hopefully managed to impress upon you the importance of osteoporotic fragility fractures, what is our optimum strategy? We wish to reduce the incidence of fractures. And can I just emphasize on that? It is not about improving the bone density scan. It is not about giving them teriparatide or denosumab or bisphosphonates. The whole purpose of assessing and treating osteoporosis is to reduce fragility fractures and to be able to assess that risk accurately, to give advice that is sensible, and that includes lifestyle advice, not just therapeutic agents. We are too focused, as certainly in rheumatology world, on these drugs. Drugs are an important part of our armamentarium, but they are only a part. Just like DEXA is an important part of the assessment of osteoporosis, but only one element of it. And that is something we need to think of carefully. So who should be involved in the management of osteoporosis? It has to be a teamwork. And one aspect of this is something that is missing in many countries, but has been shown to be incredibly important in reducing refracturing or the secondary prevention, is this concept of a fracture liaison service. Fracture liaison services were first started in Glasgow in the late 90s, and they have shown without any doubt that they play a hugely important part in the rational and accurate assessment of fracture risk and the introduction of interventions that will go a long way in preventing refracturing in these patients who are having fragility fractures. So at this point, I'll just pause and see if there are any questions within the house or on the chat. Okay, so considering that either people have been totally bored out of their minds or have been crystal clear, we'll move on. In order to treat anything, science demands that we are able to measure it, and there is a due process. So the next part of my talk will be about measuring the problem, because if you have to offer intervention, you have to have some points of reference. If you have to treat diabetes, you need blood sugar levels, HbA1c. If you have cholesterol medication, hypertension, they all require some degree of quantification. So in osteoporosis, the tool that we use is the bone density scan, or what's called the DEXA, dual energy X-ray absorptiometry. That is still the standard tool. There are lots of new things coming online, but they are not in routine clinical practice, at least not where I practice. So as I said, there's a whole range of different modalities, and they've all been tried. And I'll spend some time just to digress and tell you a little bit about DEXA particularly. So we have DEXA, we have quantitative CT scans, and I think there are centers in Bombay certainly who do QCTs. We haven't got it, and we don't use it in clinical practice. It's only in a few handful of research centers that they're doing work on it. And then high resolution MRI scan. The problem is DEXA is like an ESR. It's a surrogate marker of bone strength. So people want to know what is the truth in terms of bone fragility and bone strength. And these imagings, these advanced imaging takes us nearer the truth. So before we go any further about the exposition on of bone density, we just spend a few minutes on how the bone physiology. Generally speaking, men and women reach their peak bone mass at slightly different times of their lives. But then in women, the menopause causes a precipitous drop in the bone density. It does happen in men, but slightly slower and slightly later. But it happens in both sexes. And that's another thing that you have to remember, because in the popular perception, osteoporosis is very much a postmenopausal woman's problem, and that needs to be debunked. As I said, with the menopause, though, the bone loss accelerates, and it's like I explain it to my patients as having money in the bank. So you build up your reserves by the time you're in your 20s, and then you generally start spending it, and you spend it a lot faster after the menopause. And beyond that, for both sexes, that bone loss continues, as you can see. The other thing to remember is that there are more than one element that contributes to a fracture. And I'll take you through this. I've given you the received wisdom, the official definition of what osteoporosis is. That, to some extent, is there, but it's not incredibly helpful to understand why osteoporosis leads to fractures. So for an osteoporotic person to have a fracture, you need a few things. Usually you need trauma, not always, or not always recognized trauma. Especially with vertebral fractures, there's often no overt history of trauma, but it is low trauma, low. What is that? That is, by definition, fall from a standing height. But we only measure one element of what constitutes bone strength. We measure the bone mineral density, and as I said, it is an important element, but there is a whole range of other factors that contribute to bone quality that we do not measure, certainly not with a DEXA scan. And that's architecture, turnover rate, previous damage, and so on. And it is important for us to remember that. We cannot be too ideologically driven by investing too much importance to a bone density scan. So, as I said, I'll reiterate, it is a surrogate marker of bone fragility. And then the WHO in the early 90s came up with defining, just as you have a definition of what constitutes hypertension, what constitutes diabetes. It's a fluid, continuous system, but you have some cutoffs. The bone density is divided into normal, osteopenia, T-score of -1 to -2.5, and I'll just expand on what a T-score and a Z-score is, and osteoporosis is -2.5. That in clinical terms does not mean a great deal. It's not a finite yes-no concept. So you don't suddenly start having fractures once you cross below -2.5. Most osteoporotic fractures, in fact, occur in osteopenic women because there's a lot more osteopenic women than there are osteoporotic women. It's a normally distributed curve. Okay, so I won't spend much time on it, but just to show you that I've done my homework, this is dual X-ray absorptiometry. You can read it. There's a lot of physics involved. I have a whole textbook on a bone density scanning. It's Springer, 800 pages. When I suffer from insomnia, I open its pages and I have a very good night's sleep, I can tell you. So this is what you will be familiar. This is what a densitometer looks like, and this is the end result of a report. I'll instead expand and tell you about a little bit about the limitations of DEXA, because we take DEXA as received wisdom. It's confounded by bone size, so the size of the patient can affect what the results are. It is actually a two-dimensional juxtaposition of a three-dimensional structure, and with that, there are problems. It's like taking a picture. When you're taking a picture, you're seeing a person who's in three dimensions on a photographic paper or on the screen in two dimensions. So think of it that way. And there's a whole range of different things that can adversely increase the result or decrease it. It is not an absolutely accurate assessment of bone strength. And I keep on repeating it because that is where clinical judgment comes in. It can underestimate fracture risk if used on its own. And the other thing I have to emphasize is something that I realized at the early part of my journey. A bone density scan cannot distinguish between poorly mineralized bone, which is hypovitaminosis and osteomalacia, and less bone, which is osteoporosis. So if you have a T-score of -4 because the person has osteomalacia, and you give that person bisphosphonate, you'll do them no favors, which is why it is important to remember, and that is why sometimes doing the vitamin D is important. And vitamin D deficiency is endemic in the world, pretty much, not just in India, it's everywhere. So these are some of the measurements. We concentrate on BMD because everything in osteoporosis clinical trials and in clinical practice is dependent on the bone density scan on the BMD, but there are other parameters that can be looked at as well. So this is what a T-score and Z-score is. A Z-score is the measured BMD minus age-matched BMD, which is not difficult. So if you have a 23-year-old lady, or let's say 19-year-old girl, you take a whole bunch of other 19-year-old girls and then, subtract the measured bone density of the index patient with that mean of that, and then the age-matched population standard deviation, you get a Z-score. Z-scores are important in younger subjects and also in cases where you're suspecting secondary osteoporosis. The T-score is measured bone density minus young adult ethnically matched patients. So there's no point in applying white Caucasian figures, and sometimes you have to be very conscious because those figures may not exist. But our machines come from the States or from Europe, and if they put in parameters that are applicable to the white population, you will get erroneous results. So we'll go over this. So some few more practical points, and they are slightly more difficult to implement in India, where patients are getting their scans from different machines and also maybe not necessarily with the same machine. It is important, ideally, to have the scans longitudinally in the same machine. There is this concept of minimal significant difference, and the accuracy is much better if you do it because there's variability within the machine. It's certainly more variability if you have one done in Pune and one in Bombay. And when do we repeat a There is also a practical issue. There are some worried well patients who started bisphosphonate will come and say, I need another scan. I want to see if the drug is working. There is really not much to be gained if you keep on repeating bone density scans at 6 months or 1 year. The suggested interval is at least 2 to 3 years, because this is not that sensitive in picking up very subtle changes. And then there are the technical aspects of interpreting scans. So in clinical practice, just a few important points. The correct performance is very important. And at the IRA workshop in Hyderabad, Puneet Mashru is in Bombay, he gave an excellent talk about the pitfalls of DEXA and how the interpretation can vary because of the technical inexperience, the positioning, all kinds of different things. It's not like an X-ray that you don't have to rely on the radiologist's report. If you have the skills, you can interpret it for yourself. But in the bone density scan, you don't really know if there are ways of measuring, but we are not all that expert. So we rely on the report, and sometimes the report can lead us astray. And then you end up making major mistakes in diagnosis and treatment. But what are the strengths? It is accessible, low radiation dose. It is still one modality which has good precision, short scan time. It can be done quite quickly. And there is a lot of data about DEXA scans. We've talked about the disadvantages. There is often questions whenever I speak about osteoporosis is what is the value of quantitative peripheral scanning and so on. The pros is peripheral DEXA and heel ultrasound. They offer a quick, cheap, and convenient method of evaluating, but they are not really truly useful in initiating and maintaining treatment. And they don't correlate well with central DEXA, which is the standard DEXA we should be using. So, what are the sources of error in a DEXA scan? There are errors of measurement. Quality control, I've already mentioned. Acquisition of images can be affected by artifacts, poor positioning of patients. I've mentioned about demographics and comparing it with a different demographic population. And also it is operator dependent in terms of its analysis. So the area of interest can vary between operator to operator. And that is why you need experience. Then, of course, there's the sources of error with interpretation and quality control. So I'll touch very briefly, and I think this is the last slide on DEXA, is the concept of least significant change. And that is why you need to wait a bit longer than a year or 6 months to repeat DEXA scans. And also remember, there is also a general attrition of bone density if you did nothing by about 2% a year. And the least significant change varies from machine to machine, from manufacturer to manufacturer, and all of these things need to be kept in mind. So I'd probably end my DEXA section here. You should ideally do it in the same machine. We talked about when to repeat it, and then some special scenarios and the technical aspects of interpreting DEXA scans. Sure. So that is why I have paused. Points to discuss. Yes.
One question. How notoriously important are pioglitazone and statins in precipitating osteoporosis?
The question is, just to repeat, is how does pioglitazone and statins affect bone health? There is an emerging body of data about different drugs. These are two. Then there is a wider other drugs that we hitherto were not really seeing very much. Anti-androgens, anti-estrogens. Breast cancer patients are surviving much. Before I go to pioglitazone, let me say diabetes is a very, very important contributor to osteoporosis. And that needs to be put into context. So if you have diabetes and on pioglitazone, I'm not really aware of the additive effect of it's on bone health. But diabetes on its own, and when you think of the quantum of problems we have in India with diabetes, that is a very important risk factor that has not yet been incorporated in fracture prediction tools, but that is about to change. So just for those of you, I'm digressing, I'll come to fracture prediction tools in a minute. Those of you who use FRAX or FRAX India specifically, if someone has diabetes, you take the rheumatoid arthritis slot. That is roughly the same. Was there any other question? Statins. Don't know the data, to be honest.
It's one of the questions.
Kavita, do you know?
I have one question. So one is when patients have osteoporosis, some classification, risk, etc. So do we overestimate the risk for there?
That's a very important question. We always do, and we have to ignore it. And I'll tell you how it works out. So let us say I have a 75-year-old rheumatoid who I have done a scan, put on an oral bisphosphonate. Then maybe 5 years later, she comes, the age of 80. And a lot of these patients have degenerative spinal disease anyway. So the first scan you accept as that people have eliminated the osteophytes and done it accurately. Maybe they haven't. But then after 5 years, quite often you find that the spine bone density has gone up by 20%. And the hip bone density, the femoral neck and the total hip are either the same, which is fine, which means that the drug is being taken and working, because normally the attrition would be 1 to 2% a year. So that hasn't happened, or it has improved a little bit. That should send alarm bells. You cannot have such a dramatic increase in spinal bone density, although it is also true these drugs have differential impact on spine and hips. But when you have this sudden 24%, 22%, what that tells you is that it's osteoarthritis and osteophytes. So in a way, you ignore that. How do you then make clinical sense of it? If they've had a vertebral fracture, then this increase in bone density is irrelevant. And if you want to decide on treatment, you deal with the hip bone density. FRAX involves the hip bone density. So in a way, you're getting around the problem. There is another caveat to that. FRAX is not designed fundamentally to look at treated patients. The premise of FRAX is postmenopausal patients or men who have not started treatment. It's for you to make that therapeutic decision. But we still use it to get a ballpark figure of where they are. And there is data from Canada where they have said it is a reasonably valid tool for treated patients as well. Although purists in the osteoporosis world will say, no, FRAX cannot be used for. But, FRAX is like a general thing. It is not the be-all and end-all of our treatment decisions. And that is why I say, the more you learn about these things, the more you realize it's very much dependent on people's clinical skills and knowledge. So the answer to your question, it is very important to keep that in mind, because you can get swayed. Oh, spine is 15% increase, or is a wonderful drug. Actually, it isn't.
So for DEXA scans, is it that the PMC should be seen or calculated rather than the DMT?
I know this was brought up in our in SIG. Look, I have not come across a single trial or study where the BMC is the endpoint that they're looking at. So I honestly don't know. I know Avinash is very keen about it. And in a way, I think it is a more accurate measure of the bone strength, if you like. But everything in the osteoporosis world hinges around the bone density, irrespective of the caveats and its drawbacks. Sandeep? Please.
We have a lot of camps in periphery with calculated DEXA scan. you mentioned about terminal ultrasound, but I think they talk about terminal DEXA scan. Peripheral DEXA, they talk about. And patients come with the different reports. See, I have got low, I have got high.
See, the question for those on the Zoom is that peripheral DEXA. So peripheral DEXA, I think, is more the wrist, isn't it? Do they do it for the heel as well? I've seen heel ultrasound scans that then translate into bone density reports. We have, certainly in the UK, it was in vogue about 20 years ago because it was easy to do. As I said, and I've done a bit of reading around it because we don't have it anymore. So it's no longer in daily clinical practice. It's not a problem I see. It's good to have a general idea. You know, if there's one point that Dr. Venkatachalam, who's a very close friend of mine in Wolverhampton, and he runs one of the biggest osteoporosis services in the UK. He mentioned some facts that, you know, there is like, how many rheumatologists do you need per 100,000 of population and so on. So there are figures about how many bone densitometers you need per population unit, whatever that is. We are far below that. So the reality is that we will never have enough bone density scanners in India, and it will be concentrated in the metropolises rather than so when you're faced with a situation like that, if you have something that at least gives you some idea of what the bone density scan is, you can't necessarily use that as an alternative to central DEXA, but you can use it to get an idea. And then you have the FRAX, which you don't need a bone density scan. FRAX was designed for use in primary care. And you can do it with a DEXA for better results, but you can do it without a DEXA. So in the periphery where you don't have a scanner or you have something like a, peripheral DEXA scan, that I honestly don't think can serve as an alternative, but it can give you an idea. If someone is really osteoporotic, then if they have peripheral, why do you need the scan? Fundamental question is to decide on whether you put someone on treatment or not. If you can do it with the help of a peripheral scan and make a more informed decision, then that's fine. But to say that it is somehow an alternative to central DEXA is not something that is accepted. What was your next question?
Yeah, sometimes during DME reports, what we get, and one area is substantially lower than is it reported, like in forearms, -3, -4, and in other meters, it's normal. So sometimes we fail to interpret this report.
While preparing for, so the question for those in the Zoom is there is wide variation in various anatomical areas. Now I can see from the reports that I've been sent by preparing for this, and I've got another talk in Mumbai tomorrow, and I've got a few cases from there. They have scanned everything and all parts, even the skull. It's like a whole body MRI scan. The received wisdom is you only scan the hip and L1 to L4. That's it. Occasionally, people with the bilateral hip replacements, you can do the lower third of the radius to get an idea. But none of the fracture prediction tools or anything actually is centered around the radius. The question then is, does it matter? I would say if you have a forearm DEXA scan T-score of -3 or 4, that in a way is a fracture waiting to happen. You've got an indication that that is a very severely osteoporotic wrist. You look at other clinical risk factors, do a FRAX, and make a judgment that says you put them on treatment. I think it's best not to get too hung about these areas because they all do it differently. The standard DEXA report is still L1 to L4, total hip, femoral neck. That's it. The people who use forearm DEXA, and I got into a bit of an argument with our radiographers on this because I wanted to do a forearm DEXA for someone with bilateral hip replacements and severely osteoarthritic spine are the endocrinologists who use forearm DEXA scans for hyperparathyroidism treatment assessment. It's not that commonly used in the osteoporosis work. Okay, are there any questions?
I want to ask.
Please.
Visualization defects can also interfere with your interpretation. So how often is over here, visualization defects are quite a lot in India. We have vitamin deficiency, osteomalacia much more than the rest of the world.
So, and it's something we see. So the question for those in the Zoom is mineralization defects or osteomalacia can affect the T-scores and make it much lower than actually it should be. What I would probably say one practical way, and people are looking into this whole business of vitamin D estimation. It's quite an involved and controversial area. Do we measure vitamin D? If we do, how often do we measure it? They're not cheap. And it's okay if you're looking at middle class, upper middle class patients and they can afford it. But if you want to roll it out as national policy, you've got to be really careful. And what is the gain? I would say, and that's my personal opinion, if you suspect that patient will have hypovitaminosis D, give them 400,000 vitamin D in whichever uprise D3, fill them up with vitamin D, and then do the scan after. See, a bone density scan is not time critical. If someone has had a low trauma fracture, you should put them on treatment if they have other clinical risk factors. You know, a 70-year-old lady with a low trauma fracture, you're not really interested whether they have a DEXA scan or vitamin D or whatever. So I would say the vast majority of our population, if they think they have vitamin D, give them the vitamin D upfront, front load them. And if you want to do a DEXA scan, and remember, if you use the FRAX, and one of the things is, I don't get paid by Sheffield, who are the sort of, but FRAX is very underused. It's a wonderful tool. And FRAX is designed, there's FRAX India, it's free. Just use it. And if you use it, they'll say, do a bone density scan. And if you do it, then you think, okay, does she have poor nutrition? Does she have celiac disease? All those things come into play. And if you feel a vitamin D, say, costs quite a lot of money, you can get a lot more of vitamin D for that money and just give it. They're not going to get hypervitaminosis D, right? With 500,000. What would you say, Dr. Chopra sir?
I'm enjoying the talk. At least in India, there's a lot of data. So the question that you said about mineralization defects, clinical perspective doesn't matter. Because all these patients are going to get vitamin D calcium, something else. And I think our point is very well taken that if I can extrapolate from my clinical practice based on all that we read, the indication of bone mineral density measurement is indeed limited. In many situations we will read rigidity factor. No requirement. The best of the guidelines say rigidity factor itself is good enough for us to initiate the treatment. And you won't talk about treatment. Won't go into that. But do fracture negative for one of them orthopedic people, they should be aware of it. They don't think of rigidity fracture when they fix people. They don't think of it. Elderly people that you said, you don't really get it. You don't need to. Clinical situation also, you don't need to. So many situations you can circumvent PMD and based on clinical situation. Mother had a fractured neck of him, lady of 55, 60 years old. You don't need to. And what you said, I agree with you. FRAX, question, the way I looked at the data was that FRAX is validated for many populations. FRAX is giving a 10
probability of fracture or 10 years probability of fracture. So it does help you in the risk factor, but really, like you rightly said, it's not really the diagnosis of osteoporosis. And in our rheumatology setting, for you and me, when you fill up the cracks, you don't account the dose of fluid. And then just serve yes or no. And doses matter.
Don't steal my thunder. I'm coming to fracks, huh?
The point that when you have that, please refer to that. There are some modifications.
Yeah.
Cracks which, not like that. And if I can ask you a question.
Please.
To ask you one.
Go on.
So, what about the biomarkers of bone turnover? I mean, I what would you recommend on the serological markers and degenerative markers?
I'll touch up on it.
Yeah.
I haven't got slides, but I will tell you the received wisdom now.
Back to you.
Okay.
I was way.
I know, I was looking at you very carefully. You know, if the hint of a nod, I would have come straight over. All right. So unless there are any questions from the Zoom audience, we will go on to, I'm conscious time is running off. So what happens? You've listened to Dr. Arvind. You have restricted your bone density to the only people who actually need it. You've done it in a reliable center, and you now have a report. What then? So if you cast your mind, those of us who are of a certain age, back to the 1990s and early 2000s, you see minus 2.7 on a bone density scan report. You start them on, it was etidronate those days, or daily hyaluronic acid, and you throw away the key and forget all about them. And these poor people stay on it forever and ever till they either die or have something, and they don't come back to it. We have come a long way from that. We have become more sophisticated in translating this test into something that makes clinical sense. And the next part of my talk is how we do that. And there are more than one ways to salvation, right? And one of these ways is what I'm going to discuss, is that was evolved in the University of Sheffield by a very learned and clever man called John Keynes and his team, and his successor is Eugene McCloskey, and that is a FRAX tool. I have to emphasize that is not the only fracture prediction tool around. There are a number of others. In fact, there's one other in developed in England, and also in Australia. There's the Garvan index, but by and large, FRAX dominates the scene. Okay. So fracture prediction score. So you have a T-score value. You want it to make sense for this patient who sat in front of you. So this is about transforming a statistical score to a therapeutic decision-making. And you're doing it on the basis of one aspect of what constitutes bone strength, which is bone mass. We are conscious, but we cannot measure those other aspects, which is bone structure and bone quality. And that is where, because with that bone density scan, you're going to go from here to there. That is our journey, or not. You may just say lifestyle, eat more healthy food, take more exercise. And, this is not an inevitable outcome of doing a bone density scan that shows osteoporosis. And in order to influence that decision, we use this. And we're going to talk a little bit about FRAX. With the trainees in the audience, can I ask how many of you are aware of FRAX and maybe use it in your clinical practice? Oh, that's very good. Very good. I asked this of a British trainee audience, and there's even less, so I'm reassured. All right. Now, I need you to concentrate on this slide for one reason. And the reason is you have a T-score of minus 2.5, but the fractures that happen at minus 2.5 is not the same in all ages. Okay, so the risk of a fracture in a 50-year-old is much lower than at an 80-year-old. And that is why we need the fracture prediction tool. If you used the T-score, you'd be treating all of them the same. And that would be offering treatment to someone like in their 50s, and that is not correct clinically. And that is why we need to extrapolate the bone density to a fracture prediction tool. And also, what is the other main component is fracture risk does not increase linearly, but it's kind of exponentially when you keep losing bone density. Or in other words, the simple thing to remember is with every standard deviation loss of bone density, your fracture risk doubles. So from -1 to -2, twofold increase, -1 to -3, fourfold increase. And that is important to remember, which is why you have to be very careful in deciding your intervention thresholds. And there are a whole range of other factors that impact on the fracture risk that are not measured. You're only measuring the bone density, which is useful and important. But as I said, I showed you a picture of people looking at an elephant blindfolded. You have only one view of that elephant. So these are some of the other factors that can affect that person's fracture risk. And I keep going back to the central premise of my argument is the whole idea of osteoporosis is not about bone density, it is about preventing fractures. All we are doing is trying to triangulate all these various elements, clinical history, clinical demographics, bone density, other fracture risks, into coming up with a sensible therapeutic approach. That is the purpose, preventing fractures, not improving the bone density, not reducing the bone turnover markers. They do that in trials because they can't think of other things to do. And in short-term trials, the event rate is very low. So then they take surrogate marker and say, look at this wonderful, the bone density increased by 8%, because the event rate of fractures in these trials is very low. So they look at surrogate markers, and we are led to believe that if the pathophysiology makes sense, then fracture risks are also going to get improved. That may or may not be true. Okay, which is why you have post-marketing surveillance and long-term registries and all the rest of it. So these are some of the things that can affect fracture risk, which are not captured by the bone density, just to remember. And as I said, I'm reinforcing the fact, if you have a bone density which goes down by 1 standard deviation, your risk of fractures goes up twofold. And the other important thing to remember is the maximum number of fractures is in osteopenic patients. So if you have intellectually agreed that you will treat osteoporotic patients, you're going to miss out all those patients who are not statistically osteoporotic, but are at high risk of fractures. Hence the need of coming up with a tool that allows you to capture those patients who are going to benefit most from intervention. Am I clear? Good. Please ask questions, If I know them, I'll answer. I didn't know about the statin, I'll look it up. I did remember reading it, but senility is creeping in. All right. So this is what FRAX looks like. These are some of the risk factors. They're based on epidemiological data. And then at the end of it, you look at, where is it? You get a 10-year fracture risk and hip fracture risk. The weakness is if you've got 85-year-old lady, what does a 10-year fracture risk mean? So there are some of the other fracture tools, they have, you can shorten the time and look at it. And this is the other important thing. So you have a 10-year fracture risk and a hip fracture risk. So what? 20%, 5%, 10%. How do you then extrapolate it into a clinical decision-making tool, and hence the importance of intervention thresholds. So you see the intervention threshold, right? So this is where the intervention threshold is in the UK. And there's various ways of looking at intervention thresholds. If you are a fan of the Americans, most people, my colleagues in India are, the American guidance is 20% and 5%. They have fixed thresholds. The British are slightly unsure of themselves. They sit like sitting on the fence, and they have a moving threshold depending on the age, which I think is more scientific, and so on. Indians there is a lot of work around fracts in India, and there is Nagendra's work. They have looked at, and I can synthesize and summarize it for you into one little sort of sound bite. I'll tell you in a minute. The other thing is, if there is a difference between the hip and the spine, if the hip is not too bad, osteopenic, but if you have a spine that is -3, -3.5, and the hip is -2.5, you're using the hip as your fracture prediction workout in the fracts. But that is not truly representative. You are only as strong as your weakest link. So if your lumbar 4 vertebra is your weakest link, and there's one other point I've seen in the Indian reports, they do a L1 to L4 and they look at everything else, right? Forearm, left humerus, occiput, but they don't give details of L1 to L4. I mean, the ones I have looked at. It is important that you know, because L1 to L4 summation might be 2.7, but there you have L1 at -2.2 and L4 as -3.2, and that is where the fracture will happen, right? So it is very important that we demand that they give all the 4 vertebrae individually. Going back to my central premise here is, if there is a discrepancy, you have to apply a correction. And that is what I have worked out. See, if this patient has a hip of -2.2 and the spine of -3.3, if you use -2.2 and you come up with these figures, they may not be above the intervention threshold. What do you do then? You increase. There's a difference of -1, right? For every -1 standard deviation difference between the hip and the spine, you increase by 10%. So that is the correction. So then you increase the 10-year fracture risk by 10%. So major fracture risk here is, instead of 16, is 17.2. And that you might find, when you map it out, is above the intervention threshold. So this is a very important trick, is to, if there is discrepancy between the spine and the hip, Dr. Krishna mentioned about the spine being abnormally high, but in accurate, where there is no osteoarthritis, the spine is lower than the hip, significantly lower, you have to apply correction to the fracts. This is the work from Venkat, and they applied both the British fracts and the Indian fracts to their South Asian patients, and there are differences. And that is why it is important for us to use the one that is designed for India. So I was saying about intervention threshold, the USA have 20%, 3% fixed. The Brits are slightly more flexible and fluid. And I've talked to you about the Indians, and there is data there, and there are tables you can actually print out and keep in your clinic to decide whether they are above or below the intervention threshold. And nowadays, the latest NOG guidance have come up with high risk, very high risk. So that is to stratify your intervention. And the intervention there is in high risk and very high risk. We are offering a couple of things. One is parenteral drugs as the first line. So IV zoledronic acid is very popular in the UK. Or if you can use anabolic drugs. So I'm conscious we're running out of time. So this has now been refined further by the Sheffield team, and we have Frax Plus. And as Arvind was mentioning, the steroid dose is important. Diabetes isn't in the old Frax. The frequency of falls and the immediacy of falls. So if you've had a falls 3 months ago, your subsequent fracture risk is very high the closer to your fall. And therefore, you have to multiply a factor of 1.6, 1.7. All of these things are done in this Frax Plus algorithm. The catch is you have to pay for it. They've caught on to the fact that Frax is used by the world. Now they want to make money out of it. So there is a tariff you have to pay to use Frax Plus. But Frax Plus is a refinement of Frax. There you go. So you can see previous fracture, you can say where, you can say how long, and they'll adjust your probability. So it makes the tool far more responsive to other things. And the only message I'd like to highlight, I'm conscious of time, is all these things do not replace clinical judgment. If a 70-year-old has had a low trauma fracture, just treat the patient. Don't go about scans. Fracture takes 2 minutes, you can do it, but just treat. So this is a summary slide. You can read it. It's very busy, but it kind of summarizes the things I've talked about. So I would put it to you that a working knowledge of how to prevent fragility fractures is a responsibility that we all share, irrespective of our medical specialty and whether we are in primary care or secondary care. And there is a huge opportunity, particularly for rheumatology, to actually do more about it. And this is the end of the first half of my talk, although it's 2:30. Very little. There are figures. I know it's 50 or something, seven. It is all. You don't even need special protection to put in DEXA machine, because I know I had one put in one room in the outpatients in one of the hospitals I work in, and you don't need lead lining anything at all. I mean, you clearly don't want to go there while they're doing it, but you don't have to wear lead aprons, nothing. Very, very minimal radiation. And there is quantification, there's a table which shows how much HRCT of the thorax, abdomen, how many, radiation of chest X-ray, this is great. The bone density comes right below DEXA.
Tax plus is on payment, isn't it?
Yes, you get a discount if you're from India. It's quite, from sort of what to call, now they're politely called emerging economies, not third world or whatever. It's all about semantics with the Western guys, right? So emerging, if you are in the emerging economy, but it's still, quite expensive. It's about €1 per calculation, not cheap. You'll get it for 50 cents, which is still what, 40, 50 rupees? You charge it to the patient.
Needs it.
Well, you do when you're not sure. Barn door patients you can treat, but there are some shades of gray, and then you have to have some, because, I'll tell you why you need it. There are two groups of patients where you need it. One, there is the worried well, who demand treatment when they don't need it. And remember, everything has a cost, not just rupees and paise. There are costs. These drugs have consequences. You have to give them for a long time. And then they will sue you if they have an ONG or something. So you have to be very clear to them that I'm not giving you the treatment because of these reasons. And if there is any, discord, at least you have something to show why you have made that decision. Now, your patients think of you as God, so they'll do whatever you say. But our patients will take us to court. But jokes apart, there's also another group of patients who don't want to go on to the drug because of what someone has said or what the press have said, and they desperately need the treatment. So if you can show them a table and this little cross in the fracs, which is high risk, that sways their decision. Ultimately, we know for a fact that you can write the prescription till the cows come home. Only less than half are taking it at the end of 12 months, oral bisphosphonates, which is why in the high-risk group, we now all give them IV-Zol.
Obviously, wax is a good tool in education tool. Population screening tool.
But it has got its limitations, like everything else.
Tell me, is it required in UK, for example, that you need to calculate the day? So what I'm trying to say that clinicians, I'm not aware of,
The gradient of decision-making is inversely proportional to your experience and knowledge. So when we hear the real experts of osteoporosis say, so I would treat. And you think, why? Then it's like coming to the conclusion of an equation in mathematics, and you've given the answer, but if you've not worked out the steps, you won't get full marks. So that is where it is.
Cracks came out of hospital.
Sheffield.
Sheffield. Were the guys who made it, were they orthopedic people?
No, they were bone metabolic doctors.
They were
Bone metabolic doctors. The Sheffield has a huge bone metabolic unit.
What?
Bone and metabolic diseases, yeah.
endocrinologists.
Well, there's a bit of both. There's rheumatologists and endocrinologists
Interesting.
and basic scientists, yeah.
It's interesting how everyone fights on osteoporosis.
Or ignores it, you know.
I think the maximum noise is made by endocrinologists.
Okay, I'm supposed to do something to go to the next cases. What do I do? Okay, let's end show. Oh, I want to end meeting. God. Sorry. Sorry. So far, so good. Those of you who have not actually dabbled in osteoporosis, do you find this accessible? Am I making sense? Huh? So what is the key message? One of you will have to be my scapegoat. You can volunteer. So what are the 3 or 4 key messages from the trainees that after an hour of me going on, what are the 3 key messages that you will take home today and use in your clinic tomorrow? Senior PGT कौन है? बोलिए.
DEXA scan
So my question is.
The first was to use DEXA scan in the sense of clinical judgment. So we should not just go by the actual values which we get. And once we get the DEXA report, it's always pragmatic to apply the FRAC score and then decide on the treatment. And FRAC score also, when we use it, if the patient has diabetes, as you mentioned, then if for correction of it, we can use the rheumatoid arthritis as being present. And we have to use the correction for the FRAC score for the calculating the risk of osteoporotic fracture if there is a difference of more, depending on the difference between spine versus hip.
That's excellent. Thank you. I think that's quite useful. And we talked about why osteoporosis is important. It is an emerging epidemic, if you like, that's global. That leads to fractures, and fractures lead to costs for the health care systems in the countries where these fractures happen, and cost to the individual. Now we are going to discuss, I think time is limited. I'm conscious that we've got half an hour, so I will quickly discuss a couple of cases which I thought were excellent cases, because those are the cases that we see every day that Professor Krishna has supplied. I have a few cases. And there's a request from one of my very senior colleagues from Bangalore, Dr. Mahendra, that I should touch upon male osteoporosis. I have about half a dozen cases. I'll just touch upon those 2 areas and then a little bit about treatment, and then we shall draw a line under today's session. Okay. So the first case, you can read it. This is a lupus, 25-year-old lupus lady who had a pretty stormy, and Kavita, you can add anything, you know, so she went through a very stormy course, especially in the last year or so. And you can see this, good going lupus treatments with, serious immunomodulation and steroids, because she was not responding to these. We're talking about Methotrexate, azathioprine, even mycophenolate, which are very powerful drugs for those of you who don't use it every day. And then further evidence that the disease wasn't well controlled. And why is this important in a discussion on osteoporosis? Is when your back is to back, when you're back to the wall, the only savior in these instances is often intravenous methylprednisolone. And of course, nowadays we have rituximab, but it's very expensive, and sometimes you're not sure there's infection or not. what is lupus activity, what is infection. So as a holding drug, methylprednisolone is very useful, and quite rightly, she received pulses of methylprednisolone as well as cyclosporine. And then you can see the really stormy course in the past year over a period of 4 months. And she was dependent on high dose steroids. So far, so good in the sense, not good for her, but we know it's a young lupus lady who is not responding to fairly high doses of combinations and conventional immunomodulatory treatment, and had to go on to methylprednisolone pulses followed by oral medication. And then what happened is there is 78 grams of prednisolone over 4 months. You know, that's serious steroids, life-saving in her case. So now the osteoporosis took. So backache. Initially described because, you know, myalgia, arthalgia, common active lupus, quite right, but persistent. And you're thinking, what are the possibilities? So again, who is going to be a volunteer here? What do you think? Chalo, aap hi ki aaj hai. You're it. You're the only one not wearing an apron, you see. So, so what do you think might have happened? Why this young woman has persistent backache?
So actually, this was the case we had closely followed up in the last
Oh.
1 year.
Okay.
So when she had come to, initially she called us up and said she had a low backache, and that time she was not very sure if she had a fall or no. So she was attributing it probably to the disease activity because she was under for almost 3 months and had just started mobilizing then. So, but we attributed it to the disease activity and told her to come back if it was persistent. And when she did come to us, we started examining her because she complained of specific areas which were tender. Then when we saw that there was point tenderness, then that's when we drove down the line.
As they say in the New England Times, it prompted you to do a diagnostic procedure. We'll talk about it. But can I just digress a little bit? This is a young lady, obviously, but the vast majority of our patients who are older, who get put on bisphosphonates, either IV or oral, there are a small number will say, oh, I don't know about the osteoporosis side of things, but my back is better. And most of them will say, what, you gave me this drug, nothing's changed. And that is a very important point, is because a lot of them have mechanical back pain. They often see osteoporosis, there is no immediate existential benefit from taking these drugs. It's for them is hypothetical. You are saying you take this drug, you will avoid fractures. They've had a fracture, so that is in their mind, and they've gone through a lot of trouble if they've had a hip fracture, you know, come into hospital, had an operation, all the rest of it. But if it's a wrist fracture or even a silent spinal fracture, so what? Their expectation sometimes is they'll take these drugs and after 3 or 4 months, their back pain will get better, and it doesn't. And that is an important thing to remember. And it takes a lot of time and persuasion and explanation to say why they're taking the drug and why their back pain isn't better. Although we know that bisphosphonates have been used for treatment of osteoarthritis, but that's a separate thing. So just remember that. And managing patients' expectations are important because this is not a drug, it's like a 7-day course of antibiotics. It's a very years and years. Anyway, coming back to this young lady. So not you this time. Who will volunteer? We need a new volunteer. What can you see? The arrow says it all. Anyone?
So this is an X-ray of your spine.
Yes.
So that we can see that there is a compressed fracture of the L1 vertebra.
So a vertebral compression fracture, and that explains why she has pain, right? And you can see the bone density scores. Now, that in itself will not be caused by 4 months of steroids. So one would think that there are other factors contributing to her osteoporosis. That's one thing. Right now, the cause of her osteoporosis is academic, What you're worried about is this young lady who's going through a very difficult time with her lupus. You're throwing everything you have, in the book at her. And then in order to help her, you've given her steroids, and that may have tipped her over. And I don't think the steroids over a 4-month period would have made her so osteoporotic, except steroid-induced osteoporosis is the most rapid in the first 3 to 6 months. That is important to remember. So you could argue that actually that fact that she's had so much steroid, that is what has contributed to real worsening of her osteoporosis. But whatever the cause, she has quite significant osteoporosis. Now, I have highlighted the T-score. Is there a problem with that? Does anyone have any issue? I did it on purpose. Go on. Yeah, that is true, but she's 25. So what I should have done is highlighted the Z-score, and that's the point I wanted to make. This was done purposely. So when you're looking at a young woman's bone density scan, you look at the Z-score, and they're almost identical, with a little bit of difference. She's 25, her reference range is people her age, right? So this is a question I have for Professor Krishna. She underwent surgical correction. Was it a vertebroplasty she had? Is that right? And that is an important thing. I'll tell you about vertebroplasty later on. We don't have any orthopedic surgeons in the audience, do we? Anyway, we did a series about vertebroplasties with mixed results. Part of the problem is it's designed to help with the pain. There is a thing called kyphoplasty, where they introduce a balloon and blow up the vertebra. That is slightly more complex, and that reduces the curvature. But vertebroplasties, we had a series of 10 patients over 3-4 years. We had a very friendly radiologist who used to do this. The problem is if you don't get them at the right interval, she obviously had it very soon, and maybe that might have given her more relief. We don't quite know whether she got better with it in symptomatic terms. If you do it soon enough, it works. But a lot of them, when it becomes slightly more chronic, vertebroplasties don't work. And if they have multiple level fractures, the radiologists don't want to do too many of them. Interesting. Calcitonin, we hardly ever use in the UK. You used to use it in a whole variety of conditions, 20 years ago. With RSDS, complex regional pain, all kinds of things. But calcitonin, is it something you use quite a lot? Or was it for pain?
Many of patients we find that just 1 month of calcium spray, 1 pump daily, reduces the pain considerably, which the NSAIDs and don't do. So
Right.
just for a short time, we give just for the pain.
That's perfectly reasonable. And that is where its role is. It's still a very effective drug for bone pain. But she's on a more decent drug, teriparatide. Treating young patients is always a complicated issue. Do you give them bisphosphonates? Do you not? In this patient, I think with the severity of osteoporosis, an anabolic drug is the right drug. The question is, she's 25. You probably give it for 2 years. And there's another thing I think I should highlight because I'm conscious of time. Giving teriparatide for 3 months, as I'm told is the practice in some areas, is really unhelpful. And the reason is both teriparatide, denosumab, even raloxifene, their therapeutic efficacy is offset very, very quickly, unless you follow it up with other drugs. So either you give it as it is meant to be given, which is for 18 months to 2 years, and then you must have a plan of following it up with a bisphosphonate, possibly zoledronic acid for 1 or 2. You can even give a one-off zoledronic acid. It's called locking in. So you lock in. Once you've given the anabolic drug, the way I explain it to my patients, you poison the osteoclast so that they're not eating away the bone again and reducing the bone density. You know, the analogy I use is, you know, in the highway, you see people digging up the tarmac and then new surfaces being laid. So the diggers are the osteoclasts and the people laying down the bitumen are the osteoblasts. So what you're doing is sending the diggers for lunch, long lunch, and then getting on with the rest of them. So that is the other thing that I think is important to highlight. Teriparatide is perfect. Calcitonin is incredibly important if she's in a lot of pain, but you must have a plan.
So 2 years of peri-peptide, followed by bisphosphonates, 3 to 5 years, then what?
See how she is, you know, then if she has osteoporosis, which will improve. And young people don't need a huge amount of interventions. Quite often we don't do anything because they don't fracture, even if their BMDs look terrible. And that's what I have come to learn talking to the osteoporosis experts, because my hands are reaching to give them something and they say, no, it should be fine. And again, experience comes into it.
Uh, How much improvement in bone density we should be happy with? Suppose we do next year, it takes this time.
I would not necessarily repeat the bone density scan in a hurry. I'll tell you why. If it doesn't show much improvement, what will you do? You will be disappointed, the patient will lose faith in you and be even more disappointed. No, seriously, what you want to show is, 8% increase in bone density if it doesn't happen. So I would not, in her case, I wouldn't. Normally, there is about between 5 to 8% increase per year with anabolic drugs. That's all very good. In her case, I would just carry on for 2 years, give her one of bisphosphonate, see how she is, if she doesn't have any more fractures. Hopefully by then you've got a better handle on her disease and you're not giving her anymore. See, lupus and osteoporosis is a whole different ballgame altogether. There's various other aspects. It's not just GIOP that's important in lupus. There's a talk on lupus and osteoporosis, I think, in this Kolkata lupus initiative thing that Pathajit is doing. Anyway, so I would, in her case, just give her the drugs, assuming she actually self-injects for 2 years. To get a 25-year-old to do these injections every day for 2 years is quite a task. Let us say she does it. I'll follow it up with an IV Zol. And maybe 5 years or at least 3 years down the road, I would then see what the bone density is. Because the purpose of a scan is to determine your therapeutic alternatives. You fired your biggest gun. There is nothing more you can do. You understand?
Option of adding denosumab over
But you could add Zol or denosumab. That's not a problem. The problem with denosumab is how long you're going to give her denosumab for. Denosumab, if she's, you've got to give 5, 10 years. Are you going to do that? I would probably give her a one of IV Zol and see how she does. Or even 2, 3 years of Zol. Here is where subjectivity and, you play it by ear. There is no roadmap to these patients. Everyone does it slightly differently.
Important issue is of compliance. When you treat blood pressure, before the patient blood pressure is getting osteoporosis. I think one of the reasons bone mineral density to whatever data gone through is not very sensitive instrument to show the change of the therapeutic response. And in very first few slides that you put up, there's a very good slide, which I think many of us we never talk about, and I'm glad you put it there. To me, that's a very important key clinical message which went across. So put up a slide very clinically significantly. Remember that? That's not something which we were talking about a couple of years back. Because we were information. Did you see that? 5.6%. How often do you see a change of 5-6% in DNA? Then most of the drug trials that have taken place have shown you changes of 1 to 4%, except for this teriparatide. For the first time, we saw 9% or 8 or 9% change. Otherwise, the changes hardly ever go beyond 1 to 4%. What do we get the message? PMD is not good. And many times patients do come to us, and I'm sure you remember, if they go through a PMD, doctor will badla already, takes out again. So these are the problems with this, but here I think, Dr. Kaushik allows me, we need better biomarkers, and I think there's a reason why we need maybe the so-called serological marker and nuclear markers. Some of them are good now. The CTAX and the N, they do show, and I think if nothing else, they change very rapidly. So in 3 months, you tell the patient, I'm not making you drink Ganges of water or something, hey, what happens? That's very important to me. I mean, at least in practice, at least in prior practice, patients very often ask you, correct.
So I think
So that's the other compliance issues, all the world issues. So that's a problem. You'll be sure, because if you know there's no change, like you rightly said, they think usko 2 saal, 3 saal tak. She will take it, maybe she's in a particular setup, they should take it, not setup. So we do need to treat these patients, but I think we need to tell the patient upfront, tell them that it's a silent is by and large, unless you have some other complication. You depend on data and literature saying that this is what.
for her, it's not silent. She's already had a fracture, so her compliance will be better.
Compliant to some extent.
Yeah.
First grade improvement, I think the nightmare, we don't have any grade 2, so you want this sometime.
Okay.
Running.
Yeah. Well, I've got 10 minutes. So I think I'll do the second case, Kavitas, and maybe a few months down the line, we'll have a Zoom session on all the other things we've not touched upon. And I know Dr. Mahendranath is very cross with me if he's on the Zoom that I haven't, but we've only got 10 minutes. Let's see. I'll try and squeeze it in if I can. So I just need to say a few things about vertebral osteoporotic fractures. The vast majority of these fractures go unrecognized, and they are certainly under-recognized in clinical practice. And that is why you have two concepts. In some hospitals, when radiologists are reporting CTs of abdomen, thorax, if they pick up a vertebral fracture, they send a message to whoever is leading the osteoporosis service in that hospital. It could be the endocrinologist, it could be the rheumatologist, and they have a short circuit, fast track, and then there's osteoporosis nurses who bring them, and so that's incidental finding on other imaging that happens, in the tens of thousands in any big hospital. So that's one good way. And then there is this vertebral, the bone density, VFAs, vertebral fracture assessment on the DEXA scans. There are computer softwares that will actually measure and tell you in the BMD when they do the vertebrae if there is VFAs. So vertebral fracture assessment. So there are ways of picking these up using the current technologies and using the patients without necessarily exposing everybody to spinal x-rays. We were at one point, everybody with back pain used to get spine, lateral and AP. And then in the last 15, 20 years, we've stopped doing that. Where you think it's indicated, we do MRI scans. Except for these patients where the plain film is very, there's still a place for spinal plain films. This case illustrates that. But as I said, that almost 2/3 of vertebral fractures, no one actually recognizes till they're picked up incidentally. And unless they are picked up in time, there is this, this huge spike in more fractures. There is a dictum in the osteoporosis world which says fracture begets fracture. That is ultimately the most important clinical risk factor in osteoporosis. If someone has a low trauma fracture, their risk of having another low trauma fracture goes up manifold, as you can see. And the human cost, I go back to the human cost. It is not about us or its molecules. It's about the people that are suffering these fractures. And it's a spiral that ends up with 23% increased mortality for all the reasons that are outlined in that slide. So the key message from this case is stop at 1 if you can. Prevent. For us in hospital practice, we have to practice secondary prevention, evaluate risk factors. If you can, set up a fracture liaison service with your orthopedic colleagues. Measure sensibly, knowing all the caveats around bone density scans, and then treat pragmatically. We just touched upon vertebroplasty and kyphoplasty. It's the same kind of scenario as an ILD, and again, it's about another vertebral fracture. I will just have the last few slides, and I promise we'll come back at some other time. I'll probably come back virtually, and we'll touch upon all the other things I wanted to talk to you about, which is treatment, bone turnover markers, and its practice. That will have to wait for another day. I wish I can carry on for another 2 hours, but I think you've had enough of me. So again, someone who had a fracture, the same principles, teriparatide, calcitonin, which are eminently sensible. I did have male osteoporosis. It's not as though I don't have the cases, Dr. Mahendranath, if you're still there, but we will come back to it later. I think we'll call it a day today, if that's okay. Thank you very much for your attention. Good. What's the question?
There are two questions, both are about denosumab.
Yeah.
Can you explain the role and can you follow the denosumab with these components?
The role of denosumab, okay.
And its dosing. And second question is another person, can we follow denosumab with best components?
Excellent. So, very good questions. Denosumab is a ranked ligand inhibitor. It works slightly upstream from osteoclasts. So the whole process of how osteoporosis occurs, the final common pathway is the interaction between two cells. One is the osteoclast and the other is the osteoblast. Osteoblasts make bone, osteoclasts eat away bone. Bisphosphonates are like PPIs. They work on the proton pump, or in other words, they work on the osteoclast at the pole face. Denosumab, if I can use that analogy, is like a histamine antagonist. It works slightly upstream by blocking one of the molecules that activate osteoclasts, which is RANT ligand. So that is its mechanism of action. Ultimately, it does is inhibits osteoclast. It's given 60 milligrams subcutaneously every 6 months. One thing to remember about denosumab, it's a separate talk, but I'll just very quickly say, it's a very, very, very effective drug. The difference between denosumab and bisphosphonates is even with intravenous bisphosphonates, there is no plateau effect. After about 3 to 5 years, you do not go on acquiring bone. Your bone density kind of goes up, and then plateaus. Denosumab, on the other hand, you keep on getting better and better. And people use it for very long periods of time. The problem with denosumab sometimes, and that is the second question, which is very important, is we do have to stop denosumab for one reason or another. Either they have an infection at the injection site, they have some kind of allergic reaction, they don't like it anymore, there's, they often have fractures despite being on the drug, and they say, no, we won't have it. So you have to switch or stop for some very valid reasons. In those situations, not only should you give a bisphosphonate, it is imperative that you do. Because if you just stop the denosumab and do nothing else, what happens then is that the bone density goes in the other way. Within 6 months, it can often go below where you started. It's called the rebound phenomenon. And the patient will end up having more fractures. And in fact, close to where I work, people were taken to court because they were not given the Ivizol or anything else. They just stopped. They were stopped for a very valid reason, but you have to follow it up with a anti-osteoclast, anti-resorptive drug. It could be oral bisphosphonates, or it could be parenteral bisphosphonate like zoledronic acid. The other thing to remember with denosumab, and this is also very important, combination and sequential therapies are involved a lot. Two things, two key messages. Denosumab followed by teriparatide can counterintuitively cause a drop in the bone density. There is a very, very important paper in Lancet Endocrinology Metabolism, a study called the DATA trial, where they looked at denosumab followed by teriparatide, teriparatide followed by denosumab, and teriparatide and denosumab together. The combination of these two drugs were the best, but obviously it's expensive. The problem with denosumab followed by teriparatide is the bone density drops. There are physiological reasons for it. So ideally, the best option for sequential therapy is teriparatide followed by denosumab.
It is like first name bisphosphonates or teriparatide. Denosumab should follow. And if you stop denosumab, it should be followed by bisphosphonates.
Correct. Anti-resorptive drugs.
Thank you so much. Thank you so much, Kaushik, for an excellent overview of osteoporosis. I'm sure we have a part 2 of the virtual session where you can just have question answers and some topics that you want.
Yeah, yes. We will have another Zoom session, and I'll rope in Venkat as well. So don't worry. And can I just thank for those of you who persevered on the Zoom on behalf of Professor Kavita Krishna and the team here at Bharati Vidyapeeth, the chair, Dr. Chopra, and myself. Very big thank you to you all and for your questions. Thank you.